Okay. Okay, so thank you. It's a pleasure to be here at Dr. Lalit's symposium. This has always been a well-attended one. So I'm going to talk to you about center involving diabetic macular edema, principal paradigms, my approach. So the pathogenesis of DME, I think that's important to understand, is hyperglycemia is a prime driver, and by triggering a bunch of biochemical pathways, it pushes out a number of cytokines and chemokines. One and primary amongst this is VEGF. So when we are using anti-VEGF, primarily we're only addressing this component. But see, there are a number of other players, and this is the reason why we have this component of refractory DME, which is significant for DME. And then by altering blood-brain barrier, increasing vascular permeability, you get a DME. So management of DME is evolved from laser photocoagulation in the 80s through the turn of the millennium, where we had Tricot and the current anti-VEGF conglomerate. Okay, so the management challenges are straight and simple, as well as the tough tackles, and I'll begin with the straight and simple. So the guiding principles gleaned from the trials governing DME management, first of all, we need to know what works. Then we need to know what works best. And then what works if the patient presents to us late. And then if we hit a wall with anti-VEGF therapy, what else can we work with? So what works? A bunch of trials are there which have unequally shown that anti-VEGF has high efficacy versus sham. What works best? This DRCR protocol T looked at the three main protagonists, aflibercept, ranibizumab, bevacizumab, and they showed clearly that aflibercept and ranibizumab had a clear edge over bevacizumab in terms of equity improvement, and aflibercept slightly better than ranibizumab at 2 years, and even so with macular edema reduction. So clearly, the two takeaways from this is that higher efficacy for aflibercept and ranibizumab over bevacizumab in patients with acuity less than or equal to 20/50, which is like 612 parts. If it's better than that, you can use either of these. And clearly, bevacizumab reduced macular thickness the least. Now, what do we do if we have chronic untreated DME, or patients that have been lasered for a long time and still there's a lot of DME? So this is a case where a middle-aged lady came in with chronic DME with severe NPDR. We advised anti-VEGF. Again, she defaulted, came later, and by which time it was PDR, and so we had to add PRP, and then ranibizumab. So over 8 months with 6 injections, she persisted with anti-VEGF, and you can see fairly remarkable resolution. So this tells us that acuity can be improved in untreated chronic macular edema with persistent anti-VEGF treatment. And this is borne out in the trials RISE and RIDE, which shows us that these ranibizumab arms, as soon as they were given ranibizumab, they take off. But you see the untreated arm, the sham arm, hardly gets off the floor. And then at 2 years, with 2 years of chronic macular edema, the moment they allowed ranibizumab treatment, that graph starts snaking up, equity improves. And the same was seen conversely with macular edema. Moment after 2 years of chronic edema, moment it's allowed ranibizumab, those maculae start thinning out. Another case where again a middle-aged male diabetic, grid laser done, you can see those spots in the multicolor and the IR image. And then we advised anti-VEGF, again patient defaulted, came 2 months later. But then once they were regular with anti-VEGF treatment over 7 months, you see that the maculae thinned out. And this also shows us that therefore acuity can be improved in lasered chronic macular edema with anti-VEGF treatment. And this is also borne out in clinical trials where the RESTORE extension showed us that the two ranibizumab arms again took off, but the lasered only arm, the blue line, stayed on the floor. And again, after 1 year of chronic DME, the acuity started improving the moment they were allowed ranibizumab. And lo and behold, at 3 years, it caught up with the ranibizumab laser combination arm. So it tells us that A, don't hold by your hand if it's chronic, go ahead with anti-VEGF. Number 2, it doesn't seem to make a difference whether you put that ranibizumab laser combination at the start or put in ranibizumab 1 year later after laser. At the end of 3 years, the one was the same. Also, the USP for laser, we think, is that it will reduce the number of re-injection rates. But this study shows that the number of re-injections is the same. So it's always not true. And up to 25% of the time, patients across all the treatment groups did not require ranibizumab injections. So what works if you're late with DME treatment? RISE and RIDE and RESTORE showed us that in both untreated eyes as well as laser-only eyes, it's never too late for anti-VEGF treatment, and chronicity is perhaps overrated. Also, adding laser doesn't always necessarily reduce ranibizumab retreatment rates. Now, what else works? What about lasers? What about the role of steroids? So protocol I looked at that, and they had 2 arms, ranibizumab with deferred laser and ranibizumab with prompt laser, and this showed that both of them are far better than laser-only eyes and steroid and laser. And in terms of acuity at 2 years, deferred laser was better than prompt laser at 2 years, at 3 years, as well as at 5 years, as well as in reducing central macular thickness. Now, this is a very important slide. So this shows that in both those ranibizumab combination arms, getting a fix on that DME very intensively in the first year, you see 8 and 9 injections, will dramatically reduce the number of retreatments you need to put in the subsequent years, so 2 and 1 and 3 and 2. So it's a beast that you need to get a grip on early, and it's important to tell your patients that, and up to 43% of patients required no ranibizumab retreatments in year 3. Also, issues of elevated intraocular pressure, glaucoma, as well as cataracts were only seen in the IVTA arms. So basically, the takeaways: ranibizumab laser combination was better than laser, better than IVTA laser. Deferring combination later was better than prompt laser. And early intense treatment, this is important, reduces treatment burden later. Of course, higher safety issues were seen for IVTA. Now, anti-VEGF regimens, the monthly dosing, we started off with that. Of course, we know it has best of efficacy, but issues of economic burden, not practical, infection risk time, etc. Then we graduated to PRN, which was strict, equity and OCT-based criteria. But then, even then, number of hospitals visits were more. So then we evolved into the treat and extend regimen, and the RETAIN study was the first which compared treat and extend with the impressive results of PRN, and they found that the same results were kind of replicated with treat and extend. So that is something we can do. Now, when a patient sits in front of us, what are the guiding principles? What are the clinical factors that we need to look at? For that patient, in that eye, fundus picture, OCT, best corrected equity, but equally important, know the fellow eye status also, and then look at the systemic profile. So use this organized kind of nomogram, and then rule out masqueraders. Also, it's important to know that dosing history of the posology, what drug was used, what dosing strategy was used, was it adequate? And in our population, it's important to also know the patient factors, the compliance issues, financial issues around this patient. So these, on the right side, is a list of mitigating factors where, equity is compromised because of RPD, generation, macular atrophy, etc. And I'll show you some examples. Here, when it's like that, you need not, you can desist from an aggressive treatment policy because, you're hitting a wall there. But if you have encouraging factors like this pure clean edema with or without subretinal fluid, suboptimal vision, which for me is about 618 to 4/60, you can pursue a more aggressive factor. So these are some of the mitigating factors: macular ischemia, subfoveal fibrosis, hard exudates in the macula, outer retinal tubulations, macular atrophy, and the surgical factors, vitreomacular attraction, and epiretinal membranes. Fellow eye, if there's good vision, you can desist from a very aggressive regimen, but if it's one eye, you might have to chase. Systemic factors that aggravate macular edema, like glitazones, nephropathy, hypertension, anemia, need to be watched out for. History of stroke, myocardial infarction, allergies needs to be asked for because you might want to step away from bevacizumab. So the first general treatment is monthly anti-VEGF injections until equity is stable, visual acuity, OCT is unchanged over 2 or 3 visits. If those mitigating factors I listed were there, then you can go for a wait or observe and extend follow-up up to 2 months. If those clean and encouraging factors are there, you can treat and extend. If it's stable, extend follow-up up to 3 months, or if it's unstable, go back to treat and extend. Now moving to the tough tackles. If the dosing is adequate and you've hit a wall, then you can switch it. You can move from a lesser one like Avastin onto Accentrix. And this is generally what we've seen, the patient refractory in Avastin, Accentrix. But please remember, I've even seen the opposite, where Accentrix has been given and Avastin has been of benefit. So it's not always true one way. And then there's the history is replete with articles where moving on to a higher anti-VEGF like aflibercept as well as faricimab has helped for patients refractory to ranibizumab or bevacizumab. Now the million-dollar question is there a role for steroids at all in DME? So the MEAD study showed us that dexamethasone 0.7 milligrams did improve patients previously treated and refractory with laser or anti-VEGF treatment. So there is a role for steroids. And this is coming back again to that pathogenesis where I showed you those number of agents which are non-VEGF, which are drivers of DME. Now, this is a very interesting study from Korea. Huang has showed us the role of hyperreflective dots in identifying non-responders and taking that steroid option. So they found that hyperreflective dots were far more in bevacizumab non-responders than bevacizumab responders. And 75%, 3/4 of the bevacizumab non-responders responded to Ozurdex. And interestingly, hyperreflective dots were more in Ozurdex responders than non-responders. And that makes intuitive sense because we know hyperreflect dots are a marker of inflammation, microglia, molar cell debris. So therefore, there is a definite therapeutic role of steroids in anti-VEGF non-responders. But of course, you keep in mind the the IOP and the cataract issue. Now, a head-to-head between an anti-VEGF and steroid. So this Bevacizumab study looked at bevacizumab versus Ozurdex. Of course, overall, bevacizumab did better, as you can see on the left panel. But then, when you take cataracts out of the equation, in the pseudophakic population, you see they're almost the same. And on the right panel, you see that Ozurdex gets a more swift response in reducing macular thickness. So it is a decent option in pseudophakics. The USP of Ozurdex is in post-vitrectomy DME. So very often when we are post-vitrectomy, we find DME there. So there is no other drug where the kinetics will not be changed by the lack of vitreous, like in Ozurdex. So in elderly pseudophakics, IVTA is possible. Why I say elderly is because in youngsters, the IVTA can cause a greater percentage of IOP spike. Ozurdex for vitrectomized eyes. Then the natural question, does adding steroids to anti-VEGF help? Is there a superadded effect? So DRCR protocol, you showed us that adding dexamethasone transdermal offered no significant advantage in terms of equity, but yes, in terms of thickness reduction, macular thickness reduction. Sohail and Wang showed that adding IVTA to Avastin offered also no significant equity advantage. Now, when we are treating DME repetitively, what we are not realizing and what is happily happening is that the background diabetic retinopathy is also, that rate of progression is reducing. So that's another effect. That's another, kind of an offer you can tell patients that, when I'm treating this, your background retinopathy is also benefiting. So in diffuse DME, combination is okay. And if you're doing combination, deferring that laser is a better idea. Also, the role for laser, focal laser, is still there in non-center involving DME. So please remember, don't dispel your laser machines. They're still valid in non-center involving DME. Epiretinal membrane, VMT, are surgical issues. Vitrectomy is required. Please keep in mind, ruling out masqueraders is important. And you need to look out for hypertension, MACTEL, and X-linked retinoscopy is a rare case, especially in young patients. This vertical palisading mimics DME. New laser systems, we talked about it just now, micropulse subthreshold laser. If we're part of that society and we are bringing out guidelines, the yellow 577 nanometer is very good. 5% duty cycle is what we profess. Contiguous treatment, you can paint that maculae. There's less RP damage, as you will see. There's hardly any signature on the autofluorescence and microperimetry. So I'll leave you with this last slide. We've also looked at, which is kind of summarizing everything put together. Other alternatives are increased frequency of injecting anti-VEGF, dose hike, dose cocktail, but I've really not found these of benefit. Future directions are subthreshold micropulse laser as an alternative to repetitive anti-VEGF therapy. Illuvine is something that's coming on, we'll be excited to see. Thank you for your time.
Thank you, Anand. Are there any questions from the House?
Yeah. Just to comment that once you reach the stage where you stop treatment for DME, don't forget to look out for PDR.
Oh, of course.
Because anti-VEGFs modify the retinopathy, and so you might land up with a bigger problem than you bargained for. So please don't forget that. That's the important thing.
A question for the House, including you. Question for the panelists, including you. Does Ozempic increase the rate of diabetic maculopathy?
Well, I'm not very sure.
Ozempic, does that increase the rate of diabetic maculopathy?
I don't think we have clear level 1 evidence, but there's a lot of talk about that recently. Yes,
yeah.
I agree.
I think one of the I don't think it affects the macula. It affects one of the side effects of Ozempic is blurring of vision. Now that could be because of fluctuations in blood sugars, but also it's been associated with non-AION, so NAION.
Yeah. So two issues with Ozempic. This is I'm telling because this is now the topic for virtually everybody. One of the main risks of Ozempic, of course, is non-arthritic AION. And that is a scary thing. It occurs in 1% of people. So in case you have to advise somebody, you should keep that in mind. But the second important thing is, in patients who have diabetic retinopathy, non-proliferative diabetic retinopathy, Ozempic should be started with caution because it can precipitate increase in macular edema. So that's the group where you have to be careful. But in patients who don't have diabetic macular edema or don't have diabetic retinopathy, apparently it does not cause.
Yeah. I think the other thing that's going to come to the fore is in non-responders is the OCT angiography or OCT angio, because that quite often you're hammering away and you've got enough macular ischemia to explain everything. So that would be one of the things that you could do in a macula that's not responding. If you don't have OCTA, well, just do a standard angiogram. At least you'll get an idea of central ischemia.
The other thing is that with faricimab, it's supposed to have a effect on astrocyte apoptosis. So it's possible that the neuronal changes that occur may be reduced in patients who are on faricimab, but that results we don't have just now. We don't have the actual results in a clinical studies.
Yeah, borne by statistically significant results.
The experimental basis is there, but it's only after a few years we'll get to know. Yeah.
So I just wanted to ask, for a non-compliant, non-affording patient, will you advise vitrectomy for exudative DME? Non-compliant, non-affordable
for what?
patient. Vitrectomy for exudative DME.
So basically you're asking the role of, see, once you take the vitreous out, the standard which I showed you is where there is a tractional component, be it epiretinal membrane or vitreous. That is the standard they're saying. Once you take out the vitreous, you must remember immediately all these drugs, if it doesn't work, it will work immediately, but if it comes back, it will work immediately simply because of the oxygenation that, that is more accessible to the 9 layers now. All right. But the fact is that you're removing the vitreous, and after that, you're only left with Ozurdex as an option. And the first thing you said is a non-affordable patient. Yes. After that, all your drugs will last only a few days. So then I won't recommend that. And of course, it's an invasive option. That's another thing you have to understand.
And if the patient is non-compliant, then it's going to come back again. Systemic control is extremely important. If you operate, remove the exudates, they'll come back.